Assalamu alaikum. Welcome, everyone. We are so delighted to be with you in this conference, and thanks for the invite. It is a group of clinicians from the UK and Ireland. My name is Abdul Sadiq Hassan, Ahmed Abdul Sadiq Hassan, one of the AD consultants in the UK and Ireland. We have Dr. Ashraf and Dr. Bassem and Dr. Muhammad Al-Husseini, two emergency medicine physicians, consultants, and Dr. Husseini is an ICU consultant and acute care. So today, I know that it's a diabetes conference. However, sometimes DKA could be straightforward management, could be challenging. So today we are going to discuss, inshallah, some tips and tricks around DKA. So we'll take it as a case-based discussion for the group. So, and it's a real case we've seen. So we'd love to share it with you. I'd like us to start with 1 second. Um, I'd like to start with Dr. Al-Husseini. We have a case. Your shift is starting, Dr. Husseini, now. And before we start your case, just to highlight to the audience the four more objectives we are going to discuss today about the DKA. So we are going to ask ourselves, is it DKA for this case? Is it DKA only? Is the DKA protocol appropriate? Is it enough to apply the DKA protocol? And according to the progress of the case, you will get or we will get these questions answered together. So I'd like to start with you, Dr. Husseini. You are in a busy ICU shift, not as busy as ED. However, it's a 22 years old female patient. Me and you seen this patient a couple of times before because she's a frequent attender, known insulin dependent with poor compliance. She has a history of multiple ED and ICU admissions for DKA. She has no known drug allergy. She is 44 kilograms, weighing. She presented today with tachypnea, vomiting, tachycardia, hypertension, and GCS of 11. So one of the juniors and the nurses are presenting this case to you for your final um, plan. And they say to you that blood glucose is 480 milligram per DCL, bicarb is 12, and pH is 7.1. They've done urine ketones and it's 4 plus positive. So how would you like to start, Dr. Husseini?
Thanks, Sam. Thank you so much for your presentation, and usually thanks for your gifts from the ED. So, as you mentioned, we this case was well known to us. She is a known what we used to call brittle diabetes. So, as usual with any management, we start first to confirm diagnosis. So that's back to your question, as you mentioned, is it DKA? When we go through DKA and try to explain to our juniors, we said it's a triad of three things, basic three things. So as its name entitles, it's DKA. So it's a patient who's diabetic and he's hyperglycemic, or hyperglycemic if he's DKA first presentation, if diabetes first presentation, and he's having ketosis. That's for the K, and he's having acidemia because of the ketosis. So if you got the triad of the three, that's typical presentation.
So it
Luckily
should be
enough, our patient had
should be
gone.
very simple. Diabetic
Yes,
ketoacidosis, like hyperglycemia, ketosis, and acidosis. Thank you so much.
exactly.
Yeah.
So that's our patient. Her blood sugar was 480, her pH 7.1, and his ketos are 4 plus. That's straightforward. Unfortunately, with the advances and thanks to our diabetes professors who are mm, trying to make the diabetes under more control, things becomes more complicated. So first of all, we don't have to get the three angles of the triad. Some patients will get hyperglycemia, will get the acidosis. They have ketosis, but we don't detect it, unfortunately, because of the kits we are using. So when we use the kits to detect the ketonuria, the ketones in the urine, some of the kits are not sensitive for the beta hydroxybutyric acid, which is the main ketone. So they show as if they are negative, while they're actually so they're negative in ketonuria, but they have ketosis. We overcome. We try to overcome this by detecting the ketonemia using the new measuring devices where we can detect the beta hydroxybutyric acid. So that's the first challenge, to look into the kits you're using. The second challenge, as our diabetic patient gets older, or we're using insulin now more in elderly patients as well, we found that there is another spectrum where the patient having hyperglycemia and severe dehydration, actually severe hyperglycemia and severe dehydration, but they don't have any ketosis nor acidosis. We saw they are different spectrum, but as time goes on, we found that they are very similar to the DKA patients. And well, actually, we call them hyperosmolar hyperglycemic state or HHS.
Is that
So
are you
now
old
that
enough to remember that the old name, the honk?
Hong,
Yeah,
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 well,
yeah.
actually, before that, even we call it coma, and
Uh,
we found that
yes,
the patient state it changed with time.
yes,
So
yes.
now we found that there could be missing another part of the triad. The really challenging one was that because if you look at the others, all of them has hyperglycemia. The challenging is what we call aglycemic DKA. That is a new term we coined, where the patient is acting like a DKA. He's having ketosis, he's having acidosis, but his blood sugar is completely normal. Initially, there was certain patient types who present with that, like the patients who either maybe had a shot of insulin before coming to the ED, or has been starving for a while, maybe a pregnant patient as well. But now with the introduction of the SGLT, it's becoming more challenging now because those patients are siphoning their blood sugar through the urine, and their blood sugar and blood sugar is almost looks normal. To make things even more challenging, patients with SLGT usage are being used now into non-diabetic patients. So they don't have a diabetes history and they present what sounds like a DKA. So that the diagnosis is becoming more and more challenging now. But luckily enough, in our patient, she had a triad. So she was straightforward DKA. So that's my initial impression. Back to you, Ahmed.
Yeah, thank you so much, Hussein. So your plan is to start the DKA protocol. Is that correct?
We start the management straight away.
Yes, yes. Okay. So, Husseini, unfortunately, your shift has come to its end. You're lucky, so you're going home. We might need to call you back because you are on call. Uh, so now, who's that? Is that Basim starting his shift?
Yes,
So,
unfortunately, yes, I'm around.
yes, yes. Sorry, I messed up with the slide. So it's yes, Basim, you took over, or this patient is waiting in the ED, waiting for a bed in ICU, and as usual, ICU are not sending the patient home on time, so they don't have bed. So we are hosting their patients. So the nurse came to you saying that once they started the DKA protocol and we've done ABG and ECG, the case, they've done this ECG and they want you to review this ECG. Can I hand over the progress
Yeah,
of the,
please
yeah,
go home
give
now.
me a second if you don't mind. So the case is for you, Basim, now to handle, and they brought you this ECG. How would you
Thank
approach
you.
this, please?
Yeah, thank you, Ahmed. As usual, it's usually the DKA is straightforward, and but when I take any case handover from Ahmed, I feel there's something maybe hidden or some secret there, maybe some surprise. Hopefully, it's a happy surprise, but we'll see. So, the minute I took over, the nurse came running to me, telling me that the patient started to feel unwell. She's diaphoretic, lethargic, and sweaty. So we looked to the monitor, and this was the ECG. And in second minute, the
Oh
ECG turned
dear.
gray.
Hmm.
So we have now a dilemma, an obstacle. What happened? Like she is a young lady, she is not cardiac patient, so there is no sepsis apparent, or she has no temperature at this stage, and she is not taking any antiarrhythmic medication. So why she got this arrhythmia? She's young and she has no family history of anything. So we left with the electrolytes. The only thing we give her was the saline. So if I usually ask the medical students when you start treating the DKE, what you will start with. If I give you the three options, what will be the safest? Would you give insulin? Would you give potassium? Or would you give saline? And the straight answer from everyone will be the saline. So saline will be a lifesaver, but it might be a killer if we didn't use it with caution with some cases. So what happened is we give the saline and the patient developed arrhythmia. Nurse came back to me. So what happened? This is as simple as that. We have some amount of potassium, and it was in small amount of circulatory volume. Once we dilute it the amount of potassium gone relatively low, as simple as that. So I'm not saying no, we don't give normal saline. We have to give the fluid. We have to correct the deficit. Yet we need to be vigilant for the dilution, and we need to be monitoring the patient yeah, pulse and ECG. Basically, the normal potassium shown in the first slide with Ahmed when they took over the case, or when they received the patient, it was normal outside the cells, so it was in the blood. Yet the deposit, or the intracellular store, was quite depleted. The body prioritized the blood. So the blood is my priority. I need the blood to be stable. I will forget about the cells. Later on, we'll talk about it. So there is no such a way to discover what the composition of potassium inside the cells, but we need to anticipate
So
that.
Basim, you
Yeah,
mean that the serum potassium could be misleading? Is that correct?
absolutely, yes. I've
Yeah.
been deceived a lot. I learned the lesson the hard way. This
Okay.
is why serious arrhythmia might appear and the
Mm.
patient might be quite unstable. So, and this will lead us to the next question. As you asked, Ahmed, with the normal potassium, or how usually the potassium will, there is no rule of thumb. Usually could be normal, could be abnormal, and this is the statistics. Yet it carry very low value. From my side, I think the initial result is unreliable. It's untrue. It's not true. It's pseudo one, if you can say. So this is on the right hand side. This is the potassium. It's quite volatile and quite unstable. And this on the left side, this is what I want you to be. I want to be gentle in approaching this. Okay, be very mindful. So I'll take a bit of zoom and go to the cell level, and we are talking about acidosis, which is part of the DKA, diabetic ketoacidosis, and this is secondary to the ketones. And we have the extracellular and the intracellular. What happens that once we start to correct, the hydrogen ion will go to the cell, and the potassium will flux outside, and this will increase the deficit inside the cell itself.
Mm.
Added to the problem when we start the insulin. So we have sodium potassium pump, and we have the insulin is the gift from the gut to get rid of the sugar from the blood. Yet it is designed to get rid of the sugar, whatever the cost. And the cost here is the potassium. So it will take with it, no one give anything for free. So this will be charged for correcting the glucose, will be a reduction of the potassium. This is the second one, or second trigger for potassium reduction. Okay, so this is the point I want to highlight with you guys. Would we protocolize it or not to protocolize it? We cannot go without protocol. What do you think, guys? We have to have a protocol, but protocol does not have brains. We have brains. We need to use ours. So we need to follow the protocol, but be vigilant for the electrolyte, which could be a silent killer, could be the elephant in the room. Mainly the potassium, could be other electrolytes, as we will see now. So this is a question for you now. What do you think will be the safest way to correct the potassium, especially with pH 7 or 7.1? So with the severe acidosis, you anticipate there will be hypokalemia, which is masked by the acidosis. Once we correct the acidosis, it will be very obvious, and everyone will see it, and you might see it before you will be able to manage it. So I don't have a straight answer. Leave it for your judgment, but keep an eye on the potassium.
So
It's not
you
all.
mean, Basim,
Yeah.
if I interrupt you for a second, you
Please.
mean, yeah, you mean that we protocolize the patients.
Yes.
However, there should be a room in each protocol for senior input and for some monitoring of the potassium and heart rate, and it's not only to depend on the protocol itself. It just needs some input, senior input, or like clinician input. Is that correct?
Yes. Absolutely, yes.
Yeah.
Let's make it triangle, if you allow me. So we
Yeah.
have the protocol, we have the physician, and you factor in the patient, because it is personalized medicine. This is what we are
Mm.
talking about now. We cannot apply, there is no universal plan. Otherwise, AI
yeah,
will take over and replace us. You need to
yeah,
put
yeah.
in that every patient is different. The uniqueness for this patient, she was tiny and her stores are quite low. And another question for you guys, what do you think will be the major cause of hyperkalemia? So we have a lot of options. We have the renal failure, we have the acidosis, we have the DKA or ketosis. So what might be a reason for hyperkalemia? According to a lot of books, they are saying the most common recorded cause for hyperkalemia is hemolysis, which we call it pseudo hyperkalemia. It is a false result due to breakdown of some RBCs. Once you break few RBCs, what will happen is the 150 from few RBCs will go out and will give you a false result and to assure you that the potassium is fine and it's not. So if we took this in consideration, we need as well to look to the other electrolytes like sodium, phosphate, and not to forget about another elephant in the room, a lot of elephants in the room actually. So which is magnesium. I think about magnesium a lot, mainly when I have a stubborn or difficult patient. I'm trying to correct the potassium and I'm giving a lot of potassium and the potassium level is not improving. So we call it refractory hypokalemia. At this
Mm.
stage, the magic will be the magnesium will be the aid, the help, the facilitator to get the potassium back inside the wall of the cells. As you can see there, they are not jumping out of the school, but they are going back to the cell.
I always say, Bassem, about the magnesium and potassium relationship that magnesium is the little brother to the potassium. So we always need to
Yeah,
remember them. Yeah.
I would call him I will call it the wise brother.
Okay. Okay.
It know
Yeah.
what to yeah.
Good expression. Yeah.
Yeah. So, and last piece in my phase in the journey, I'll leave you to the next host, which is IV insulin. Once we start the insulin, it will push everything inside. Now, I want to highlight one new update. They are talking now about replacing the IV insulin with subcutaneous insulin. It's kind of it's tricky, but let's focus on one more thing. So we agree that the IV is quick, subcutaneous is slower, intramuscular in the middle. So if we are shifting from IV to subcutaneous, there will be a gap. So the patient receiving insulin, then we stop the IV and start subcut, and there will be a gap. So the IV will work at same moment, but the subcutaneous, when we shift the patient to subcutaneous, it will take an hour to an hour and a half. So the advice is to overlap. So the last 2 hours before you stop the IV, start subcutaneous, and now you don't have any gap, which you might cause what we call it rebound hyperglycemia.
And
On
this
the
should
other,
be part of the
yeah,
protocol as well, isn't it?
yes, yes.
Okay. Okay.
So on the other hand, so the protocol are flexible. Now, as we usually say, the guidelines are there to guide you. They are
Mm,
not Quran, they are not Bible. They are there to guide.
mm,
So if we didn't overlap, the patient will get a rebound hyperglycemia. If we
mm,
give insulin in a higher dose or we give more insulin more than the calculated, the patient will develop quick hypoglycemia, which might and progress to a cerebral edema, which happen in 1 to 2% of the cases. I wouldn't exceed 50%, 50 milligram per hour, a drop from of the sugar. I'm not happy to normalize my patient. I need go gently with the patient. So that if we want to remember numbers, I wouldn't drop more than 50 per hour, and we go slow and see how our patient improve. So this is the overlap we talked about a few minutes ago, and it will be again 2 hour of overlap. I'll leave you with some take home or some pitfalls, and I learned this from the hard way. So I'm always saying to my trainees, I'm happy for you to commit mistakes. I'm happy for you to make mistakes, but please don't make my mistakes. I did it already. I made it already. So you don't have to repeat it. Be creative. So one of the mistakes we've done before, we're over skipping or overlooking the potassium level and how versatile and volatile is the potassium. I was deceived once with hemolysis, and the sample error gave me false sensation of normal value. And one day I tried to correct the potassium. Loads of time didn't work, and finally I called Hosseini, and he told me, "Why didn't you give magnesium?" Ah, yeah, yeah. Thank you, thank you for this. Next time, I have to think about
Can
it.
Bassem, can I
Yeah,
interrupt you for one more second, please?
please.
Just to highlight or elaborate more on the point you said, it's a very important point about the sampling error because we treat patients, we don't treat
The numbers.
the numbers or the investigation. Or because a couple of days ago, I was grabbed to rhesus for a patient with a potassium of 9. So
Hmm.
once I seen the VBG potassium was 9, I've rushed to the patient, and the patient was tachycardic, 150, and the ECG wasn't an ECG of a potassium of 9 at all. So I
Okay,
say
fair
to
play.
them,
Yes.
there is something, okay? And the patient clinically history wasn't like matching the potassium of 9. So we repeated the VBG and it was 3.8. Okay, so we done the serum one, and it was around like 3.9 or something. That's why we didn't start the management straight away. So I'm just elaborating or reiterating what you have said about the sampling errors and the hemolysis. It's really important. So
Absolutely.
I will leave
I
you to the magnesium and the next
Yeah,
two
I
points
would trust the monitor more than the gas machine or the serum sample. I would trust the monitor more.
because
So
it's live. Yeah.
yeah. So again, the magnesium is my thing to go for refractory hypokalemia, and I wouldn't go for overcorrecting and develop a cerebral edema, or I wouldn't leave a gap between the IV and subcut. I would overlap them to avoid the rebound hyperglycemia. Although I've done a lot of efforts to my patient, she initially improved. My shift is over now, and before I leave, the patient is still plateauing now and not improving anymore. So I'll hand over to my senior colleague, Ashraf, and I'm hoping that he will be treating her better than me, and she will be lucky to get his care. Thank
So
you,
thank
guys.
you, Basim. You can go home and rest. It's your shift is done. Now I will take over the control of the slide if you don't mind.
So yeah,
Okay, Basim, your shift has come to an end,
Yeah.
unfortunately, or fortunately for you. You'll go home, and Ashraf took over. And I don't know if it's always nice to take over from Basim,
It's
Ashraf,
never nice.
or
It's never nice
never
to take
nice.
over from Bassem.
Yeah,
Yeah, yeah. I've been watching, both
yes,
Dr. Hosseini and Bassem have
yeah.
done marvelous work with this case.
Yes,
But I'm a little bit worried. I've never taken a case
yes.
from
I
Bassem.
think I think you should be worried, Ashraf, because the nurse in charge came to you as you are the consultant charging the ED, and still the patient is waiting for an ICU bed. If maybe if the ICU people, Dr. Husseini, are doing their job and charging their patient, they might have a bed and take the patient from us. However, the nurse is really worried about the patient, and she came to you interrupting the board round you are doing, and she said to you, "We have a repeat VBG, and we expected the protocol that should have done some improvement. However, pH is now 7, it was 7.1, CO2 is 19.5, and bicarb is 8, and I think it was 12, and RBS is 250, and it was 480, and ketones in urine, now it's 1 plus and it was 4 plus. So can I hand over the patient to you because the nurses are really worried about the patient and they even worried about the patient clinically.
Yeah, yeah, yeah. I know. I'd be very worried as well. Is there any, you don't want to keep it now?
I
Okay.
know.
Okay. So obviously, like we're very, very concerned with this lady. She hasn't really made much of an improvement in terms of her acidosis. The
Yes, indeed.
sugar seems to be responding. The sugar seems to be responding. I heard she had an episode of arrhythmia earlier and hypokalemia and
Yeah, that was Bassem's effect. Yeah. So let's see what we are gonna do. Yeah.
Bassem has that
Yeah.
effect on people's hearts. Yes, that's definite.
Yes.
Okay, so I think really when we're looking at this case, the question really that we have to ask ourselves is is this only DKA? That's a question that you know we always have to ask with patients that don't seem to be responding
Mm.
to all the measures that we're trying to apply. So
So you
we
mean there could be a confounding factor or something else that contributing to her acidosis? This is a very good way of thinking. I like that.
yeah,
Yeah.
yeah, it's, I mean, often enough, you know, acidosis in the emergency department, if this patient hadn't come in with, obvious background history of insulin-dependent diabetes, previous DKAs, will we look at other causes of her acidosis? We probably will. So if an acidosis is not really responding to your classical treatment of DKA, then it only makes sense that you should consider other causes of high anion gap acidosis.
It makes a lot
So
of sense, to be honest. Yeah.
yeah, so the high anion gap metabolic acidosis is one of the most difficult things to remember. The causes are there's numerous causes that keep um, updating the causes, but like a lot of things in medicine, mnemonics are there to save the day. So when we're looking at our mnemonics in the next slide now, you will see that there's a few, and there's been kind of an evolution of those mnemonics. So in the 1980s, our older colleagues might remember mud piles was
I think he's talking
actually
about you, Husseini, about older colleagues. Yeah. Because, yeah.
they might remember that it was only mud piles back then, and that
Yeah.
would describe things, causes like methanol, uremia and renal failure, diabetic ketoacidosis, all drugs like paraldehyde, iron, and isoniazid, um, lactate and liver failure, ethylene glycol, and salicylates. In the 2000s, they decided that there's a couple of more causes that they discovered, and they decided to add them on. So it became longer, and they came up with cat mud piles. So to the mud piles, they added cyanide and carbon monoxide. They added alcoholic ketoacidosis, and they added toluene. In and around 2010, I was probably working as a junior doctor back then. The mnemonic gold mark came out, and I still use that. I think it's the most useful. It's quite succinct and quite compressed. Um, so we might go through the individual causes of high iron gap metabolic acidosis according to the mnemonic gold mark, if that's okay. So
Yeah.
if we start with the letter G, um, that stands for glycol. So they've grouped them together. So ethylene glycol, which is found in a solution called antifreeze, which is a
Is that
solution
the
that
one they
reacts.
use for the radiators and coolant agents?
Yeah, that's exactly.
Yeah.
That's the one that's
Yeah.
being used for car coolants and radiators.
Mm. Mm.
They kind of use it as well for water reservoirs, water tanks, and it
Mm.
stops water from freezing. Now, it's a
Yeah.
common uh, solvent that is used for suicidal attempts, unfortunately. So it causes renal damage and metabolizing into toxic oxalates, and those cause acidosis. Another common solvent that causes high iron gap metabolic acidosis, and Hosseini would know this from ICU, is propylene glycol, which is actually the solvent used to dilute lorazepam. So lorazepam IV contains propylene glycol. Patients who are on high doses of lorazepam for sedation often develop
Yeah.
acidosis, and our friends from ICU know to change them possibly into another medication if they develop acidosis while on lorazepam. Moving
Okay.
on to the letter O.
They just need to take the patients from the ED first. Yeah.
Yeah, that's very true. Oxoproline is also known as pyroglutamic acid. Now, it's a very interesting metabolite of paracetamol, and it only occurs. Um, well, it occurs. It is a metabolite of paracetamol. It happens due to the breakdown of paracetamol by the liver. Um, but it's very important to know that patients who take chronic paracetamol, particularly if they're malnourished or older, um, are at a higher risk of developing accumulation of this and acidosis. Moving on to the letter L, we'll start with what is called L-lactate. Now, this is the common lactate that we as emergency physicians love and trust. It's lactic acidosis due to tissue hypoxia, sepsis, shock, and liver failure. And our endocrine colleagues will know it from metformin-associated lactic acidosis. So it's the common lactate that we all know in endocrine and critical care settings. The D is for D-lactate. Now, D-lactate is actually something that is up and coming. It's only been identified recently, and it's due to fermentation within the short bowel syndrome. So in patients, particularly post-bariatric surgery patients, more so the classical bariatric surgery patients like the Roux-en-Y's, those patients have bacteria that ferment um, uh, and produce D-lactate. That also accumulates. Now, it's quite difficult to measure, and it won't show up on your serum lactate blood testing. So it requires specific assay in order to identify it. Moving on to M in the gold mark, that would be methanol. Methanol is actually, a household item in a lot of places here in Europe. It's contained in industrial alcohol that's used for cleaning surfaces. It's also contained in local brew. So locally brewed alcohol, okay?
Can I interrupt
Usually,
for a second, Ashraf, please? Is it سبرتو أحمر or سبرتو أبيض يا حسيني?
it's سبرتو ابيض. اه
Okay.
اه
Okay.
سبرتو ابيض. ف you'll find it in Sibirto, like I said, which is used as a
Yeah.
solvent for paint, and it's also found in locally made alcoholic drinks.
Mm.
Okay, so things that are made at home or made locally, that sort of a thing. Now it's a interesting the thing to know as well that it's the alcohol that's contained in our sterilium gels in the
Mm.
in the in the healthcare settings. I have had a patient that would come in and drink away
Drinking.
at
Oh my
yeah
God.
yeah they would drink the alcohol hanging off the wall. So
Yeah.
we sometimes have to hide it if this
Yeah.
particular person comes in. But it's important to know that methanol can cause optic nerve damage as well as metabolic acidosis.
Mm.
Moving on to the A then in gold mark, that of course stands for good old aspirin, a drug that's almost over 100 years old, but causes mixed respiratory alkalosis and metabolic acidosis in overdosing. It's due to the accumulation of salicylic acid and other
Mm.
organic acids that are produced as metabolites of aspirin breakdown.
If I can elaborate on this point, if you don't mind, Ashraf, I think some of the places as a routine practice when there is acidosis, they send like salicylate and paracetamol level anyway.
Yeah,
Yeah.
that's definitely the protocol in our department.
Mm.
In kind of undifferentiated acidosis, you'd send paracetamol and salicylate levels.
Yeah.
The R in gold mark stands for good old renal failure, which we all know is a well-recognized cause for acidosis, due to uremia, which causes to accumulation of sulfates, phosphates, and other acids, contributing to the high anion acidosis. Finally, last but not least, is ketoacidosis, which of course happens with both alcoholic ketoacidosis, happens with diabetic ketoacidosis, and more commonly, and we're seeing an increased number of patients that are coming due to starvation ketoacidosis in first world countries, actually, nonetheless. And that's due to patients who are actually starving themselves, for dietary choices. So keto diets and such, these are patients that go off on, go off sugars and on high fat diets. So when we're looking at all these causes, really, you know, it's I can try and fit this into what this patient is presenting with. So
I
it's a very
Ashraf, just a piece of information. When you sent one of your juniors to dig deep in the history, you found that this patient is having an arm pain for the last couple of weeks, and she's taking too frequent paracetamol to control that pain. Would this make any difference to
Yeah,
your case
yeah, yeah, yeah,
progression?
definitely, definitely. That would really definitely lead me to the O in my gold mark. So
Yeah,
particularly that this patient's weight was only what 44
44.
kilos, if I
Yes.
remember. So that
Yeah,
that would put her in a category. She's diabetic,
yeah,
which she's as I understand from her frequent presentations, she's not really well controlled, non-compliant. So it would put her in a category that she could very well be malnourished, and
yeah.
a normal dose of paracetamol that people would take might be quite a high dose for her.
For her, yeah,
So
correct. Yeah,
so
it's a very
I
good
think,
point.
yeah, I think it's quite likely that that's what the cause, and that would probably warrant, maybe, if you give me a chance to talk a word or two about chronic paracetamol use in the
Yeah, go
malnourished.
ahead. Yeah, yeah. As long as it's gonna be word or two. Yeah, it's fine.
Yeah, just a word or two. So, when we're looking at chronic paracetamol use in the malnourished, if you move on to the next slide there,
Yeah,
perfect. So, the problem with paracetamol breakdown is that it needs glutathione, which is in the liver, as we all know, um, to basically amalgamate it and then be washed out of the body through. So the chronic use of paracetamol depletes glutathione, and it then, after that, this byproduct of paracetamol breakdown, 5-oxoproline, the pyroglutamic acid, starts accumulating in the body, and that's what causes the acidosis. Um, so the risk factors for this are chronic paracetamol ingestion in the malnourished, usually female gender, and would be triggered. The acidosis can be triggered by pushing the patient just over the edge, due to sepsis or renal impairment.
so we
So
don't know the renal profile for this patient, but so the only one thing that is missing from these four risk factors is a sepsis. However, she's having three out of four risk factors. That's a very good highlighting. Thank you so much, Ashraf.
no, anytime, anytime. So that would be my 2 cents in the case.
Yeah. So, what's your management? What's your say to the team?
Well, I suppose, like paracetamol overdose. Really, the treatment is first, obviously, stop the paracetamol.
Yeah.
So the first question is, did she get paracetamol in the ED?
Bassem was kind enough to give her paracetamol for the
How
pain.
nice, how nice,
Yeah.
how nice of it.
So he was kind enough to give her arrhythmia and paracetamol. So thank you so much, Bassem, for this.
I'm still here. I don't know why. I thought I tried to help.
We'll meet in court, Bassem. Don't worry. Okay.
That's okay. That's okay. So I suppose
So
we'll stop that first, okay? And
yeah,
then
and
obviously we'll need to provide the patient with some supportive care in terms of IV fluids.
yeah, yeah. So
You
the
know, and
paracetamol
then
level came back, Ashraf, and it is like 40. So it's quite a, a little bit high for chronic use, not like an overdose.
yeah,
Okay.
yeah,
Maybe due
yeah.
to the one dose that given. But thank you so much. So we go to the management of now DKA, hypokalemia, and paracetamol overdose. I think this patient should go home. It's enough. We are
I
enough
think I think
dealing with this patient, I'd say.
Send her home with
However,
paracetamol. Yeah, give her paracetamol and send her home.
yeah, yeah, please do, Bassem. Husseini, you came in the morning and patient is still here. Your team didn't discharge any patient from the ICU, and you are doing your post-take round, and you found the patient is still not improving. Um, so one second, I'm just messing up with the slides. Yeah. So is the DKA protocol enough? So the patient, you are reviewing the patient, Dr. Husseini, in the post-take with your team, and they say to you that the patient is still acidotic, and I think she's spiking up temperature now, and you're still worried about the patient. She should have been improved. We started the DK protocol and we personalized the protocol for her, and we treated the hypokalemia, we treated the arrhythmia, and we discovered the paracetamol thing, and we are get started in style cysteine. However, the patient is still disproving. So, what would you do?
So yes, I mean, that's also actually a true story. This patient, in spite of all the effort, ended intubated because she got
Mm,
respiratory exhaustion because of severe metabolic acidosis.
yeah.
Um, and we didn't know. We thought we started with the protocol. We gave her the antibiotics. She has a fever. We're getting the infection under control. The most common cause of infection, the common cause of DKA is infection, and the most common cause of infection is usually pneumonia, UTI. Saying that,
Her X-ray is
DKA is
fine, and urine
yeah,
analysis is fine as well,
yeah,
and blood culture
yeah.
is still
So
not back.
excellent. So the thing is, the DKA is happening for a reason. So what we are been doing is trying to rectify the DKA. But the primary reason that precipitated the DKA, as long as it is there, DKA will persist, whatever we are doing. Like in this case. So we're going through what is the most common causes, and remember the in. So in is the infection, and we spoke about that. The in is the inadequate use of insulin, either omitting it or underestimating the required dose. And the third one is common the infarction. And when we say infarction, we mean myocardial infarction, we mean
Hmm.
pulmonary infarction, we refer to acute bowel ischemia, or even acute limb ischemia, especially in patients with HHS.
Yeah, yeah.
Um,
That's a very
these
good way
these
to
patients,
remember it, to be honest, Hussein. Thank you so much. Just need to highlight it to the audience. It is IN, infection, infarction, inflammation, and insulin inadequacy, inadequate insulin. So this is a very good way to remember it. Yeah. Thank you.
so these patients was still a mystery because we thought we did everything, we give the antibiotics. But when we treat infection, we sometimes we miss that infection is an antibiotic on one hand and control the source on the other hand. Luckily enough, my nursing team was thorough in their assessment of the patient. Unlike me, they examined the patient from head to toe, and they found that her actually arm pain was an arm pain. She was having an axillary tail abscess,
Hmm.
pressed axillary tail abscess, and that was she was getting lots of paracetamol. They called
Hmm.
me, and the moment we walked in the room, we saw the abscess, and we did an aspiration. The pus was relieved, and yeah, imagine it or not, in 6 hours the patient was out of DKA, and she was exhibited by
Hmm.
the morning team. So the source
Hmm.
control
That makes sense.
is
Yeah.
something shouldn't be missed, and that is the small blueprint that is not in the protocol. So the protocol is telling you what can be done automatically, but as Basim and Ashraf mentioned, you need to personalize it for the patient. While you're doing this, it's giving you some time to look for what is not in the protocol, which is finding the source and controlling. And unless you find
Hmm.
it, there is no way the DKA is going. Don't blame the protocol. The protocol is giving you
Yeah.
the umbrella to do what you should be doing. So
Mm.
yeah, it was very interesting.
Yeah, that's really good. So the I'll go back to this main slide at the beginning, to be honest, because this is the one we really need to highlight. So we gone through about these important four questions. Is it DKA? And we discovered in our scenario that it was a DKA and it might present differently. And when we asked ourselves a question, is it a DKA only? It wasn't a DKA only, to be honest. There was like arrhythmia, and there was a pastamol problem, and there was also underlying or precipitating factor, which is the abscess. So all the questions we answer. So I leave the time now for the audience to, if they need to discuss or to ask any question, um, and then I will hand
Yeah.
out the question to our prestigious speakers.
Thank you,
Thank
guys.
you.
I would like to thank our audience. I know that you are our seniors. It's your specialty. We just wanted to tell the narrative from our side. It's only the first few minutes or an hour receiving the patient, but we wanted to share some experience and some insights from our side with you. And finally, I want to thank my colleagues, the speakers, Ahmed, Ashraf, and Al Husseini. They responded to me at a short notice as I got the invitation from the conference organizer. And thank you for dedicating your time, guys. And really, I appreciate it for the hours we spent together trying to come out with this presentation. Thank you.
Thank you so much. We'll discuss later about being appreciative about these hours, Bassem, but later, not now.
Oh,
Okay.
good, yeah. Yeah. Thank you very much. Thank you.
Okay.